position of delivery, manual rotation of the fetal head, use of oxytocin, episiotomy, prenatal support, and assisted vaginal delivery. And I told you the last time that assisted vaginal delivery is not in the scope of this series of lectures, but we can come to that eventually. So when we talked about the duration of second stage of labor, we said that generally 2 hours in multigravida, 3 hours in primary gravida. Some people put another hour in it, but generally this is considered to be appropriate in women who have had epidural analgesia. The second thing we talked about was that when we talk about the second stage of labor is basically active and passive. And the active second stage of labor is important, and prolonged second stage of labor is significant because it is related to maternal and neonatal morbidity. Now the question arises is, when do we label a second stage prolonged? And that question is very difficult to answer. As I told you before, that we say that it is 3 hours in a primary gravida. But do we wait for the whole 3 hours and then declare it as a prolonged second stage, or do we start calling it prolonged if it is more than an hour? It is very difficult, and there is no upper limit identified already for the second stage of labor. So it is difficult to identify, but the important thing to realize is that second stage of labor, if it becomes prolonged, there is going to be morbidity. Now, if you look at the morbidity in terms of the mother, the more prolonged the second stage is, the lesser is the probability of vaginal delivery, increased probability of trauma, poliomyelitis, uterine probability of PPH, and increased probability of operative delivery. For the neonate, we said that the basic thing is that increased probability of shoulder dystocia, brachial plexus injury, but a greater probability of a baby delivered with signs of asphyxia, with low EBGA score, with sepsis, increased possibility of admission to the ICU, and an increased perinatal morbidity and mortality. The second thing we talked about was the support person in labor, and I'm not going to spend a lot of time on it, but I think that this is one practice that we must propagate because it is also about the psychological needs of the pregnant woman, and we have to make sure that some support person who's trained, a trained support person must be present with the woman in labor, and which is called the doula, but at least we can begin with a support person which is from the family and they can stay with the mother, which cannot happen. In very Thank you. So the third thing is assessment of the fetal well-being during the second stage of labor. Now, why do we need to assess the fetal well-being in the second stage of labor? Because second stage of the labor is the time in labor in which maximum hypoxic stress can happen. And this hypoxic stress can be due to, number one, very frequent contractions, number two, because of the maternal expulsive forces, number three, because of compression either of the umbilical cord or of the fetal head. And all these can result in the increase in the lactate levels, and the greater the maternal pushing, the more is going to be the fetal lactate levels, which can be disastrous. So, in second stage of labor, it is recommended that we should auscultate every 5 minutes. Basically, it means that we should auscultate every other contraction. But as you're all aware, we have become so dependent on the CCG that it is very rarely that we actually auscultate the fetal heart sound. So what you are doing is you are looking at a fetal heart sound from a CCG machine device. And when you are looking at the fetal heart sound, it is important to note that if there is slow recovery of the fetal heart rate, it means that there is a chemoreceptor mediated response to that. And if there is an abnormally persistent decrease in the fetal heart rate, it needs to be worried about, and you should look at the pattern of recovery. If in the pattern of recovery there is an increase in the fetal heart rate baseline, or then it is something which we need to be worried about, or there is an acceleration immediately after uterine contraction, it means that we need to worry about it, and it means that significant hypoxia is happening, and that is why the fetus has to increase the heart rate after the contraction is finished to compensate for the oxygen deficiency. Now, when you detect the presence of an atypical variable deceleration, immediately followed by an exaggerated fetal reflex response to increase in the baseline heart rate, which means overshoot. तो ये वही करने वाली बात है, यहाँ हमने खत्म किया था last time. And if you look over here, these are the overshoots. ये deceleration आई. And one more point that I want to tell you is that when we are looking at the CTG, we are all looking at the CTG without looking at the uterine contractions. So one important lesson from today is that you have CTG machines which have uterine transducers, but because of a lack of commitment, we do not use the uterine transducers. So at least in the second stage or in the late first stage, we must start using the uterine transducers. So when you put up a uterine transducer, you see that the peak of the uterine contraction is matching with the dip of the fetal heart rate. And that is perfectly okay because it happens naturally. But if this happens and then it starts overshooting, it means that there is hypoxia is happening and we need to be thinking about it. This is called an overshoot. And why does this overshoot happen? It happens because of excessive uterine activity, which means too frequent contractions. So if there is an overshoot which you diagnose on the CTG, my recommendation to you would be that you look at your oxytocin and reduce the number of drops and adjust them to a sense that only 3 contractions happen in 10 minutes. The second reason that it could happen is that there is unrecognized oligohydramnios. So I actually found it in the papers, but I would say that unrecognized oligohydramnios you would actually find in the first stage of labor, right? So in the second stage of labor, actually the membranes are already ruptured. So when the membranes are ruptured, obviously they bring little fluid out the baby. So I don't think this is a very important point, but the presence of meconium would also be resulting in the overshoot. So now you understand how deceptive second stage of labor is, that even if you are adjusting your symptoms, if these are persistent overshoots, then you should be thinking about the presence of meconium and you need to do a careful pelvic examination to see whether there is meconium or not. Now, the second thing is that what are the danger signs about which we should be worried and on which we should be thinking, and there is need for urgent action at that point to avoid the hypoxia inside to the fetus and perinatal death. So what are they? Decelerations which have a very late recovery. Now, if you look at this deceleration, the first thing bad about this deceleration is that it is not happening at the peak of the uterine contraction. It was actually fine when the contraction was happening, but when the contraction started ending, तो आपकी deceleration शुरू हो गई, which actually persisted till the next contraction. So it is a very very prolonged deceleration. So जब हम late deceleration कहते हैं, तो we need to match it with the contraction gain as well. So if that deceleration is matching to the apex of your contraction, then it is not that significant. But if it starts late and persists in the next contraction and mixes with the next contraction, तो इसका मतलब है कि इसके लिए हमें ready होना चाहिए and we need to take urgent action. So, for example, this is happening with a patient who's fully dilated with the vertex at +1 station, or I would assist them immediately. I would not wait for this for a long time. The second thing is the repetitive accelerations. Now, what does repetitive acceleration mean? वो हमने वही बात की थी जो वो overshoot वाली है, एक आगे इसकी slide में आपको दिखाऊंगी. Right in the baseline fetal heart rate. So when we are looking at the fetal heart rate in the second stage of labor, हम कहते हैं 150 है, 160 है, ये ठीक है, 170 हो गया, चलो कोई बात नहीं. We are actually somehow have this impression that if it is an acceleration, it's okay. There's nothing wrong with the baseline fetal. But the important thing is that we have to look at the baseline fetal heart rate. And when we are looking at the baseline fetal heart rate, we have to compare the baseline in the first stage of labor to what it is now. So if in the first stage of labor it was around 130 and now it is around 170 or 180 as is being shown over here, there's nothing wrong with the CTG other than the fact that the baseline heart rate has gone to 180 that we should be worried about. And you remember a patient with dengue was already running fever. So if you have a patient who's already running fever and you think that they're taking tachycardia maybe because of the fever, then you might be mistaken and you might not really realize that the tachycardia is because of a fetal problem. So I would recommend that if your lady has got fever, she should be given some antipyretic earlier on so that in the second stage of labor we have a patient which is afebrile. Rise in fetal heart rate immediately after uterine contraction, I think we've already talked about it, so I'm not going to talk about it again. Now, generally one needs to understand that the standard CTG guidelines which are used in the labor room in the first stage of labor are not the best of guidelines which are used to diagnose fetal hypoxia. So it is important to recognize the pattern, and I think that we are just repeating what we said over here and we don't need to look at this again. Now look at this subacute hypoxic pattern, and I think we talked about it the other day. And if you look over here, the important thing over here is that the contractions are coming in too frequently. अगर आप इसको देखो नीचे फीटल हार्ट रेट का यूट्राइन मॉनिटर को देखो तो यूट्राइन मॉनिटर यूट्राइन कंट्रैक्शन मॉनिटर ये शो कर रहा है that the fetal heart rates are the uterine contractions are coming in fairly regularly and quickly. So अगर interval between contractions 30 seconds है या 1 मिनट है तो fetus को रिकवर करने का मौका ही नहीं मिलता and immediately the next contraction starts and the fetus does not have enough time to compensate for this that oxygen loss. So if you read above what is written, it says that the fetus progressively spends less time at the baseline, which is less than 30 seconds, which is too small a time for the fetus to compensate for the time that it spent during the deceleration. So deceleration to आपकी 90 seconds, 90 seconds का मतलब है 1.5 minute. For that, I would have liked you to be here. उस दिन हमारे केस ऐसा हुआ था 1.5 मिनट आपकी डिसेलरेशन रही और उसको पिक करने के लिए जो आपने ऑक्सीजनेशन का फेज दिया बेबी को that was only 30 seconds, which is too little. So this is also a subacute hypoxic pattern in which there is danger. Now the thing is that hypoxia का risk second stage में होता है and I think that is very important to recognize that risk is there. But it is also very important to recognize that fetus has a mechanism for responding to hypoxia. So ज़्यादातर जब हम समझते हैं कि hypoxia होगा, hypoxia नहीं होगा. But it happens in some people. Now the question is, if there is a hypoxic insult, what is the response that the fetus that is going to be? So the thing is that most of the fetuses are going to respond to that and become alright and they will be fine when they deliver. However, some fetuses will not respond to that and how do we recognize those in which we have to take action? So I would say that fetuses with IUGR, they've got a low reserve. So इनके अंदर हमें careful होने की जरूरत है. Then if there is induced or augmented labor, I have over a period of time become almost against induction in labor and almost against augmentation in labor because it is very difficult to control the situation. So अगर आप वेस्ट में देखें जहाँ ज़्यादातर midwifery deliveries होती हैं तो वहाँ induction of labor and augmentation काफी कुछ So over there the chances of induction of labor and augmentation of labor are generally not the methods of choice. So women are allowed to go into spontaneous labor, women are allowed to proceed normally without being augmented unnecessarily. So I think that this is a very important factor and we need to keep that in mind. So the pressure on the labor room is already increased if the lady is induced or augmented and the responsibility of the managing team is also increased. Then is the presence of meconium. So meconium in itself is a risk factor. So in these women, CPT should be taken with a pinch of salt. Then maternal pyrexia hastens hypoxic injury, and we already discussed this, that when there is maternal pyrexia, there is going to be a bit of confusion because if there is tachycardia and if there is a rise in the baseline fetal heart rate, then many a times it can be mistaken that this rise in the fetal heart rate was actually because of pyrexia. Although it was not because of pyrexia, it was probably happening because of that.
रवीना अगर तुम इधर बैठ जाओ तो माइक में आवाज जाएगी.
इन्होंने मुझे इधर बिठाया.
हालांकि अगर इधर बैठे तो कमेंट्स आ रहे हैं कि नो वॉइस सर
हम स्टार्ट किया है अनम्यूट कर सकते हैं.
अच्छा तो फिर भी अगर इधर बैठ जाए तो बेहतर आवाज चली जाएगी.
ओके
और वो कह रहे थे प्लीज ओवरशूट वाला दोबारा था.
ओके ओवरशूट वाले पे कभी हम आए नहीं है. मैं कर दिया तो पहले कर चुके. आज तो बात ही थी कि ओवरशूट
की
ये वाला. Okay, so what we were saying over here was that when there is a contraction, पहली बात हमने ये की थी हाँ कि always look at the uterine transducer as well, and हमने ये बात की थी कि late first stage में और second stage of labor में it would be good to have a uterine transducer so that you are able to regulate the contractions according to the uterine activity and see the response of the fetal heart rate according to the uterine contractions. So what is being shown over here is that the presence of overshoots is not a good sign. It shows either excessive uterine activity or the presence of meconium. Excessive uterine activity का मतलब ये है कि अगर oxytocin induced activity है तो too frequent it does not get enough time to recover the heart rate और ऑक्सीजन सैचुरेशन दोबारा ठीक नहीं होती, इसलिए ये जो सब acute hypoxic pattern है, it is a dangerous pattern to have in the second stage of labor. ये हमने बातें की थी और फिर हमने कहा stage of labor is hypoxia happens, लेकिन most of the fetuses are going to respond to the hypoxia in a successful compensatory response which they can mount. But there are some fetuses which might not be able to mount that response, and some examples of those fetuses are the ones with IUGR, the ones in which there is meconium, in pyrexia, in chorioamnionitis, and sometimes the one in which there is a rapidly evolving hypoxic stress which can be there in induced or augmented labor, and that is why we said कि induction of labor के मैं खिलाफ हो गई और मैं ये समझती हूँ कि induction of labor एक तो fetus compromise के chances बढ़ा देता है, दूसरा induction of labor जो है वो cesarean section के rate को बढ़ा देता है. So we should be really careful in making the decision, and I would never have thought that I would say this. Induction of labor से पहले बहुत ज़्यादा सोचना चाहिए, क्या वाकई ज़रूरत है? अगर आपका दिमाग बार-बार कह रहा है कि इसके अलावा आपके पास कोई choice नहीं है, only then induce labor. And I would differ somewhere in the guidelines. Guidelines के मुताबिक अगर आप चलें तो you would be doing a lot of induction of labor. हालांकि जिन्होंने guidelines बनाई हैं वो induction of labor इतना नहीं करते. So काफी आप gynecologist को देखेंगे जो 37 weeks पे pre-cancer diagnose करके induce कर देते हैं. बाकी आपको मिलेंगे वो कहेंगे कि GDM आपको पता है पाकिस्तान में बहुत ज़्यादा है, 38 weeks पे induce कर देते हैं. GDM की recommendation है that if the blood sugar is controlled, 41 weeks तक आप wait कर सकते हैं. If FICO कहता है, FICO की guideline है 41 weeks तक you can wait and then only induce labor. So induction of labor की unnecessary indications उनके नहीं करना चाहिए. Even the indication for induction at 37 weeks of polystasis of pregnancy, उसके पैरामीटर्स डिफाइन करने की जरूरत है. अगर उसका जो लिवर फंक्शन है ALT ST 35 की बजाय 70 हो गया है तो इसका मतलब ये नहीं है कि 37 वीक्स पे उसको डिलीवर कर देना चाहिए. So one needs to really rethink our induction strategies. I think we have already talked about it, but एक चीज मेरे ख्याल में इम्पोर्टेंट है कि जब metabolic acidosis होता है, what happens with the metabolic acidosis? So when पहले बात करते हैं catecholamine response की, that there is an increase in the fetal heart rate, and we talked about that. We also need to talk about the zigzag pattern, which basically is showing you autonomic instability. So हमारी वो पहला जो set of CTPs था, उसके बाद हम अगले set में आ गए, which shows worsening of the problem. So the zigzag pattern actually shows that there is a worsening of the fetal heart rate, and we are going to talk about it. And the last thing that I want to talk about is the reduction in the baseline fetal heart rate, either in the count or in the variability. और जब ये होनी शुरू हो गई है तो it means it is an end stage. So खाली fetal heart rate 100 नजर आ जाना is not significant. As I said, that we have to look at the pattern. So if the pattern is that there is this reduction in the baseline fetal heart rate और वो चले जा रहा है तो इसका मतलब है there is a probability of severe metabolic acidosis and insight to the baby, and this actually means immediate delivery. So zigzag pattern क्या होता है? Let's see. This is the zigzag pattern. So इसका मतलब basically ये है कि in between the decelerations there is going to be rapid accelerations. ये zigzag pattern है और ये ज़्यादातर zigzag pattern जो होता है ये active maternal pushing के साथ related होता है. And I think that this is an important pattern to identify because when we ask the woman to push, हम उसे push करवाने का कहते भूल ही जाते हैं, उसे कहते करते रहो, that's contraction तक. That is what results in the zigzag pattern, and when we tell the patient से push कराना है और अगर pushing की बात करेंगे तो उसकी technique क्या होनी चाहिए, तो हमें ये देखना चाहिए कि we do not keep on pushing, asking the patient to push till the time that the next contraction happens. So this is also one of the signs of ongoing subacute hypoxia. अच्छा, हमने अब अपनी सारी बातें कर ली. Just want to share with you कि जो है basically क्या categories हैं of fetal heart rate patients. So category 1 of fetal heart rate patient basically says baseline fetal heart rate between 110 and 160, moderate baseline variability, no decelerations. Sometimes early decelerations may be present, but generally decelerations नहीं होती, and accelerations may be present or absent. So basically, अगर आप देखें तो there are two important things over here: baseline heart rate and baseline variability, and no accelerations or decelerations even are okay. and this is a normal fetal acid base balance reflective CTT, which is category 1, which you get most of the time. कैटेगरी 2 की बात में बात करूंगी, पहले कैटेगरी 3 की बात करूंगी. Category 3 is that if there is absent fetal heart rate variability and any of the following: recurrent rate decelerations, variable decelerations, bradycardia, sinusoidal pattern, ये सारे के सारे जो हैं एक category 3 शो करते हैं. So the question is that what is category 2? Category 2 is in between. So those patients which do not meet the criteria of either 1 or 3 are category 2, जिसमें आप सोचते हैं कि ये determined है, इसको दोबारा देखते हैं, वो category 2 है. करना क्या है जब category 3 हो जाए? हमने बात की थी last week modifiable risk factors की, in which we talked about symptosonon, we talked about the position of the patient, oxygen के बारे में हमने बात की थी, bladder empty के लिए ये बात की थी. So immediately, if you find that the CTG is not appropriate, instead of shouting for delivery and shifting the patient to the delivery room, look at the modifiable risk factors. Look at the fact कि patient की position क्या है, patient supine तो नहीं है, is there any hypotension? क्योंकि कई दफा epidural की dose लगती है and there is immediate hypotension and there are changes in the CTG. So look at the blood pressure, look at the uterotonic agent that you are giving, empty the bladder, and if it does not show any response, then it is better to. Okay, so CTG के बारे में if there are any questions, I can answer them right here. Any questions? Okay, so we'll wait at that if there are any questions. Then the fourth component of our discussion is talking about the buccal cord and its implications. And there is this study which I found to be a very important study, and it shows that cord around the neck can happen in up to 30% of fetuses. And 30% is a significant number. And we know for a fact that a lot of doctors would advise cesarean section based on cord around the neck. So for you as trainees and as developing senior consultants, I think it is important to understand that cord around the neck is not an indication of cesarean section. However, very rarely problems can arise. Mostly it is not associated with an increase in perinatal mobility and mortality. Lekin one-off, you can have a baby in which the cord is tightly wrapped around the neck and which actually causes a situation like strangulation. But it is extremely rare. So we have all experienced that babies can be born safely with multiple loops of cord around the neck and vaginal delivery can happen. And the important thing, and this one of my friends actually told me कि जब ये पढ़ाने लगो cord around the neck तो ये जरूर पढ़ाना कि अगर 3-4 loops हैं cord around the neck के तो बच्चे को खींचने से जब baby deliver हो रहा है and you keep on pulling at the baby, the loops are going to tighten. So if there are multiple loops of cord around the neck, the important thing is कि आप उसको क्या करके cut कर दें and then you deliver the baby. अगर loop tight है, अगर loops multiple हैं, they are tight and you are not able to take them off the fetal head, it is important that you, instead of pulling the baby, you just grab them. So that would be easier rather than कि आप उसको जो है वो खींचे जा रहे हैं. So इसके अंदर भी there are certain things that need to be assessed. So if you have a cord around the neck, you have to look at a couple of things. So what are you going to look at? You're going to look at the number of loops of cord around the neck. You will look at the amniotic fluid index, the gestational age, fetal growth, and induction of labor. मुझे नहीं पता मैंने induction of support क्यों लिखा था. But the important thing is कि अगर कोई risk factor नहीं है, and the pregnancy is doing fine, and there are no issues, you are good. अब if there is a prolonged persistent buccal cord with poor fetal growth, this deserves close monitoring and delivery as deemed appropriate. Presence of variable decelerations during fetal heart rate monitoring is indicative of possible presence of a buccal cord. तो तुम्हें याद होगा जब हम second stage of labor में dip आती है और deceleration आती है, हम पहला क्या कहते हैं? Cord around the neck है. So we always review the ultrasound and see whether there is a cord around the neck. So if there is, then we should be wary of the cord around the neck. बट इसमें मैंने तुम लोगों को बड़ी इंपॉर्टेंट बात कही है, वो ये कही है कि अगर fetal growth affected है because of cord around the neck, then it is something to be seen. लड़कियों हमारा इंतजार करते रहे. चलो, thank you for coming. अच्छा, अब हमने बात करनी है again cord around the neck, and I think this is the last slide. क्योंकि sometimes it can cause a prolonged partial asphyxia और इसकी थोड़ी सी evidence है, and it is a rare complication. very rare for tight pupil cord. So basically क्या है कि अगर cord बहुत tight है तो there is a reduction in the blood flow or oxygen to the brain is affected. Again I am going to say that this is extremely rare क्योंकि अक्सर औकात जो रेयर बातें होती हैं वो याद रह जाती हैं. मैंने ये बताया और सारों ने जाके कहना है कि corner of the neck is an indication for C-section क्योंकि partial asphyxia हो सकता है. This is extremely rare, but if the baby has corner of the neck and it is going well, it means you don't have any reason. अच्छा, अब हमने बात करनी है मैटरनल पुशिंग टेक्निक की और मैटरनल पोजीशन की. सो पोजीशन के बारे में तो हमें पता है कि इट डज नॉट मेक एनी डिफरेंस. तो व्हाटएवर पोजीशन हमारे यहाँ तो पेशेंट्स डिलीवर के लिए थॉट पोजीशन में होते हैं, बट व्हाटएवर पोजीशन द पेशेंट चूजेस टू डिलीवर इन, एक्चुअली वी शुड ट्राई टू facilitate that. But I think that we have not reached that point that we give the choice to the patient and ask her to choose a position of her choice. और फरूक ने एक दफा वाटर बर्थ की कोशिश की थी, मुझे पता नहीं उसका क्या बना था, बट इसके अलावा हम में से किसी ने कोई ऐसी कोशिश नहीं की. Then about maternal pushing, I think that this is extremely important क्योंकि दो तरीके से pushing हो सकती है. एक pushing होती है जब माँ की natural urge to push, she has an urge to push and she follows that urge and instinct. And the second is जो हम directed pushing कराते हैं. तो मैं पहले बात करूँगी directed pushing की because this is to be discouraged in a way. Why do we have to discourage it? क्योंकि ये pushing क्या करती है? The woman holds her breath and then she starts pushing during the pain and she keeps on pushing and pushing and pushing. So ये जो है इसको ज़्यादा encourage नहीं करना चाहिए because we said that it might result in CTG abnormalities. लेकिन अगर डायरेक्टेड पुशिंग को सही तरीके से किया जाए तो ये देखा गया है that there is no difference in the 5-minute MGA score. So not makes a lot of difference, but provided your people who are guiding the patient to push should be trained in a way that they make sure कि patient contractions के अलावा push ना करे और इतना prolonged push ना करे कि हम hypoxia को overcome ना करें. The second is the spontaneous pushing. So the women are following their instincts और वो उसके मुताबिक push कर रही हैं. This is also not a bad way and just needs a little bit of supportive care. So मैं ये कहूँगी कि natural instinct को हमें use करना चाहिए. Although you might ask the question that if women are taking epidural analgesia, would there be a spontaneous urge to push? So if the dose of epidural has been adjusted appropriately, there might be a spontaneous urge to push and we have seen that. So उसमें कोई परेशानी की बात नहीं है, लेकिन pushing एक important technique है. There is a question. Active phase of second stage is directed pushing. So it can be both. It is not necessarily directed pushing. It could be spontaneous pushing which you are encouraging, or it could be directed pushing.
यहाँ पे कमेंट कर.
जी सर.
ये जो पुशिंग वाला मामला है इसको one has to exercise some judgment on that. The patient or the woman would have that urge to push when the presenting part of particularly the head is pressing upon the pelvic floor. Sometimes the cervix is fully dilated and the head is still high up. It is not at the pelvic floor, and it would not be appropriate to encourage the patient to push at that time. Nor it would be proper for the patient to push before full dilatation, irrespective of the fetal head. Sometimes the fetal head comes down, the cervix is not fully dilated, and she would have a reflex urge to bear down, to push. At that time, the patient should be advised to resist that temptation and not to push, because otherwise that results in damage to the uterine spores. So therefore, the cervix should be fully dilated. The head should be at the pelvic floor when the patient may be encouraged to have to push at that time. But again, that solicitation of pushing should not be too strong or too vocal. We gently tell her that you just have to take a deep breath, hold it, and then bear down as far as possible. Because effective pushing by the patient doubles the forces which would push the baby out. One is the uterus is pushing, uterus is contracting, and it is pushing the baby down. The mechanism of the uterine contraction is such that the contraction starts from above and spreads downwards, and as it spreads downwards, it pulls upon the myometrium of the lower part of the uterus upwards. That is how the cervix actually dilates. But that's also a mechanism, and in the process, gradually the upper part of the uterine wall that becomes thicker, and the lower part of the uterine wall becomes gradually thinner. But that is one of the ways by which the uterus is pushing the baby down. Now, when there is an urge to bear down, and the woman pushes it, then the forces which are pushing now the baby out are doubled because of that. So it's a very, very important adjunct to pushing for the patient. But in the process, we must see that the patient doesn't get exhausted. And then, depending also upon the pushing and the pain, etc., sometimes that is, if it is infective or the patient starts wearing down too early, that also is an occasion when you should look for occipital position, because that's the kind of pain which starts from the back, and the patient complains of lower back pain, and she also has an urge to push, but those are ineffective pushes. So you have to check it from time to time where the head is, what is the position of the head, and according to that, then you encourage the patient. But don't shout at the patient, just gently encourage her to push. And when we are 3 or 4 people, not all of us should be doing that.
And you don't sound encouraging, we sound dominating, and that can't be fit with you.
Yes. So we are shouting at the push, bear down, and do all that.
Aisha हो तो
Just be gentle. Just be gentle, and only one person. एक कह रहा हाँ push करो, दूसरा कह रहा और push करो, तीसरा कह रहा और push करो. एक बंदा at a time. और mind you, full dilatation of the cervix does not mean that the patient is going to deliver and put the patient in the cot. We don't do that until and unless the head has come down. And in primary gravida, it starts, the head shows without separating the labia. You can see a part of the head at the height of a contraction. If you can see that, that means the head is pretty down. And the perineum normally is rigid enough not to really give way so quickly and so early in a primary gravida that you will not have time to shift the patient to second stage or put her in the lithotomy position, which normally we do. In multigravida, of course, if the perineum is lax and all that, then you would make the position for delivery if it is to be lithotomy when the head is at +2 station. So putting on, because when Dr. Rubina was telling you about the CTG, there was a point in which the dorsal position of the patient, lying dorsal, is detrimental to fetal oxygenation, to the placental blood flow, to the oxygen which is carried by the cord to the baby as well. Now, if you put the patient in lithotomy position and she is there for 2 hours, all the fetal weight is on the inferior vena cava, and that's a recipe for hypotension and resultant hypoxia. So we must endeavor that the patient should be in lithotomy position for as little time or as smaller time as is possible, consistent with safer delivery of the patient.
Definitely, the points that have been made by Dr. Farooq are all very, very relevant and to the discussion. और इसमें 3-4 बड़ी important बातें कही गई. एक important बात ये कही गई है that if the patient is fully dilated, it is not an indication to push. और बहुत लोगों ने इसमें से ये निकाला होगा कि हो सकता है कि हमें जल्दी पुश करवाना शुरू कर देना चाहिए. That is not true. The head and the chances of complications happening are more when you are asking the patient to push rather than when it is happening naturally. So ये important है कि जब patient fully dilated हो जाए, an attendant, a doctor or a nurse should continuously be present with the patient. Number 1. Number 2, the fetal heart rate. If you are doing a CTG, it should continuously be monitored. Number 3, no unnecessary pushing or intervention should be done if the contractions are adequate. Number 4, you shift the primary gravida only when the head is presenting at the vulva, not crowning but presenting at the vulva and showing in the labial lips. The pushing should start only when the head is deep down in the pelvis, pushing on the pelvic floor. So अगर head जो है वो 0 पे आ गया है, let's say 0 पे head है तो push करवाने की कोई जरूरत नहीं है, उसको +1 तक आने दें उसके बाद जब आप पुश करवाएंगे तो उसका एडवांटेज भी ज्यादा होगा, पेशेंट भी एग्जॉस्ट नहीं होगी, और जो मल्टीपल लोग जब पुश करा रहे होते हैं उसमें एक आई वुड नॉट लाइक टू कॉल इट लाइक दैट, बट आई जस्ट मेरे दिमाग में बार बार आती है जो एक फ्रेंजी होती है, वो जो बाजारों पे वो कर रहे होते हैं, विथ कर रहे होते हैं, और फिर फ्रेंजी क्रिएट हो जाती है। इट्स लाइक क्रिएटिंग दैट फ्रेंजी फॉर द पेशेंट, क्योंकि उसे इतने दो वे की बात कर रहे हैं, ऐसे ऐसे कर रहे हैं, तो वो मतलब पागल होने वाली हो जाती है, वो बेवकूफों की तरह पुश करना शुरू कर देती है। आई डोंट वांट टू यूज दिस वर्ड, but just to make you understand that that frenzy should not be created, because it is bad for the mother and it is bad for the baby, and it can lead to fetal hypoxia. And he also said that it is very important not to make an early lithotomy. It is very important that the patient does not remain in a dorsal position for very long. So if you have shifted the patient in the second stage labor room, it is important to put a wedge over there. If there is a wedge, the chances of vena cable compression, and a proper wedge, not just below the button or kasa karke to button क्यों हो गया, that does not change the position of the patient. So the presence of a wedge will help. और डायरेक्टिव क्वेश्चन आप करें या पेशेंट की नेचुरल पे करें, माय व्यू वुड बी that it should be on the natural instinct of the patient, but you just build it up and you encourage her to follow that natural instinct, that you are being supported by the uterine contraction and sometimes by the assisted delivery techniques, whatever you do. So active maternal pushing के detrimental effects क्या हैं, क्या हम करते हैं जिसकी वजह से उसका क्या impact produce होता है, we just need to understand that. And the one is the Valsalva maneuver to aid expansive efforts, जो कि हम सारे करवाते हैं। वो क्या करता है, it reduces the venous return due to an increase in the intrathoracic pressure resulting in reduced stroke volume and maternal cardiac output, leading to a reduction in the basically in सब चीजों से क्या हो रहा है, there is a decrease in the uterine circulation और oxygenation of the fetus जो है वो reduce हो रही है। दूसरी चीज, reduced maternal breathing during episodes of active maternal pushing, because no exchange of oxygen is taking place. Again, it is going to affect the oxygenation of the fetus. तो आप जितनी मर्जी उसको ऑक्सीजन लगा देंगे, उसका तो अपने साथ सप्लायर है ना कुछ करने। तीसरी चीज, इम्पैक्शन ऑफ द फीटल हेड डीप इनसाइड द मैटरनल पैसेज। इससे क्या होता है, इससे अगेन द सेम थिंग दैट देयर इज इंक्रीज इन द intracranial pressure, which is going to cause a problem, basically reducing the cerebral circulation. So ये सारे जो हमारे actions हैं in which we are pushing actively and we are pushing without a thought behind it are going to be detrimental to the blood circulation of the baby, and they might add to the hypoxia.
ये pushing के बारे में एक थोड़ा सा
Please, so,
वो someone wrote, I don't know whether it's difficult or easy to too enthusiastic solicitation of pushing by people may not cause uterovaginal prolapse only in the patient, but in some sympathetic onlookers as well.
yes, okay, let's look at what else is there. तो हमारे पास 8 मिनट रह गए, डॉक्टर राशिद होते हैं ना, बड़ी जल्दी आ जाते हैं।
क्योंकि हमारा वो जो है ना, जो फेवरेट सिटी है अजमेर जाफरी,
जी जी,
वो मैं क्लास में था, वो जब हमारी वो ड्यूटी लगी थी ना उसमें, तो वो साथ में खड़ा हो जाता, तो बॉडी बिल्डर था और वो मरीज के साथ
टॉक अबाउट द नेक्स्ट प्रोफेसर who is retired and very senior.
हां, वो जोर लगाओ आयशा उसके सामने कुछ भी एक बॉडी बिल्डर जोर लगाओ प्लीज।
आयशा कहती है कि हो सकता है आप लोगों को मेरे में जाने में स्ट्रेटनिंग करनी पड़े बाद। वो जो आप कह रही थी
You are not the only one. Okay. मुझे उनका वैसे कुर्सी वाला वाकया याद हो गया। तो the same guy, we are not going to name him, he was once sitting
कह दिया तो मैंने नाम
आपने
तो
कह
ले
दिया,
लिया।
नहीं सुना। So कोई बात नहीं। So he was once sitting in his office and I went there. तो वो जिस कुर्सी पे बैठे हुए थे वो ना कुछ टूटी हुई थी, तो वो यूं बैठे हुए थे ऐसे टेढ़े होके और बार-बार एक और प्रोफेसर का नाम ले रहे थे और कह रहे थे उसमें मेरी कुर्सी तोड़ दो। तो मैंने सर पानी था, मैंने इतने बड़े होने के बाद भी लोग ऐसी बातें करते हैं, मतलब people don't change. So what you are now, you are going to be that at 60 and 70 and 80, so better change now. बाद में कुछ नहीं होगा. So lateral pressure of the fetal head on the uterine vessels, again reduction in the uteroplacental blood flow, and then increasing the uterine pressure due to the strong uterine contraction and increase intra-abdominal pressure because of the active pushing of the mother. ये जो combination है और मैं चाह रही हूँ हमारे पास sister और हमारी nurses बैठी हुई हैं, it is very important to be my team का हिस्सा है कि आप ये बात realize करें कि जब हम बहुत ज़्यादा जोर लगवाते हैं और फिर तो चल रही है तो उससे repetitive and sustained compression of umbilical cord हो रही है, again leading to reduction in fetal oxygenation. Obviously, when you listen to these things, the first reaction is अपनी सारी चीजें छोड़ के फिर zero पे आ जाते हैं, करें क्या? कोई भी चीज सीखते हैं. But obviously, this is meant to put that caution in our mind that when we are pushing, we have to be cognizant of the fact that oxygen saturation of the baby is extremely low, and we have to take adequate measures.
And यहाँ पे ये बताने की भी जरूरत है कि that is extremely dangerous जब हम ऊपर से वो pressure करते हैं ऊपर से.
तो होना ही नहीं चाहिए.
वो नहीं होना चाहिए. That is very dangerous क्योंकि उससे भी और ज़्यादा उसको जो pressure.
Exactly, you are increasing that and you are live. Okay, so the seventh component of the discussion was कि manual rotation of fetal head क्या होती है और पता नहीं उस दिन कौन था जब हमने डिलीवरी कराई थी तो हमने भी 2-3 दिन पहले की थी. So the thing is that if the labor is not progressing, the head is not coming down. The important point that my message over here is that if the head is not coming down, it is very important to assess the position of the fetal head. So once you assess the position and the station of the fetal head, obviously there are various things that we can do. But one of the interventions which was specially mentioned and I want to talk to you about over here is the manual rotation of the fetal head. Obviously, it needs a certain kind of skill to be able to manually rotate the fetal head, but manual rotation of the fetal head can reduce the probability of even assisted vaginal delivery, cesarean section, compromise, etc., etc. So ये अच्छी चीज है जिसको देखना चाहिए. इसके जो advantages हैं वो ये हैं कि it reduces the chance of cesarean section, chances of PPH, poliomyelitis, perineal lacerations. लेकिन इसके अंदर cervical laceration का chance बढ़ सकता है, especially if the person who is performing the manual rotation is not very skillful. Sir, manual rotation के sir सारी किस्म की rotations के बड़े expert हैं. So if you have not watched him apply a peelant faucet, you must watch him apply.
अरे ये है कि आपको पता होना चाहिए कि हेड
ये पोजीशन है क्या
और उसको रोटेट करने की बारी तो बाद में. So you must identify.
So many people actually are not in a habit. Whenever we get a call or we are discussing with each other, many times the residents are going to only say that the patient is fully dilated or vertex is set up there. And many times we forget to look for the position of the baby. And I think that this is a very important component if you're talking in terms of the fetal outcome. Okay, then I just wanted to share with you this small trial which is RCT for prophylactic early manual rotation of occipital posterior at the beginning of the second stage versus expectant manual. So इसके conclusion basically ये थे that manual rotation of occipital posterior fetus at the onset of second stage decreases the time of maternal pushing, and clinical assessment of the position of the head is an important part of providing optimal care to the patient. Then I think we have talked a lot about this, but the uterine contractions in the second stage of labor are important. And when we are talking about uterine contractions, हमने उसकी 3 चीजें देखनी है: the frequency of the contraction, the interval in between contractions, and the interval in between contractions, the duration of the contraction, and the strength of the contraction. So normally 3 contractions in 10 minutes, contraction lasting for 40 to 50 seconds, and the second stage of labor is considered okay. Optimum uterine contractions are needed. Why do we need optimal uterine contractions? क्योंकि हमने descent के लिए flexion of the head, rotation of the presenting part, and delivery of the fetus. So basically, the whole mechanism of labor is dependent on optimal uterine contractions. But at the same time, we do not want those optimum contractions coming in too frequently. So जब हम ये कह रहे हैं कि हमारे लिए इसका उनके लिए जरूरी है, हम ये भी कह रहे हैं that we need spacing between the uterine contractions so that the fetus is able to retake its oxygen throughout the carbon dioxide which has accumulated in between. So ये तो तस्वीर तुम में से बहुत लोगों को याद होगी because you guys took the picture and WhatsApped it to me a couple of days ago when I was preparing the presentation. So now we have started making sure that the number of drops of oxytocin are properly regulated, and for the safe use of oxytocin, I think that it is very important. Yes.
9:30 2 minutes है.
2 minutes है, but we are just finishing. This will be our last slide. So for the safe use of oxytocin, the regulator should be used, and it is important to understand that the excessive use of oxytocin may be associated with risk of uterine tachycystria, postpartum hemorrhage, maternal hypolipidemia, especially if you are giving a lot of fluids, you just an antidiuretic effect of oxytocin. So it is important to highlight the safe use of oxytocin. And I think I will stop over here, and the next time we will start revise the previous one and end this presentation.
एक सवाल है
G question क्या है?
causes of cerebral palsy.
Oh, I think that this is a huge question because there are multiple causes of cerebral palsy, and most of the causes would be because of hypoxia during labor.
But now equally it is also the genetic mutation, genetic elements are also now considered to be involved in that, and hypoxia during labor is not the only cause. It is a cause in about 1/3 of the cases.
And normally because we are not monitoring the fetal pH, so sometimes you are not able to defend yourselves ably when we are talking about cerebral palsy, which was not because of the obstetrician's intervention. So I think that it is important to understand that. If there are no more questions, sir, सामने को
वो अभी म्यूट हो जाते हैं। इमरान कर देते हैं।
सर माइक अनम्यूट कर दें।
आपका माइक बंद है।
सर माइक को अनम्यूट कीजिए।
सर माइक अनम्यूट करें।
सर दोबारा तारीफ।
इमरान आप एडमिन आप भी कर सकते हैं उसको अनम्यूट।
मैं कह रहा था कि आपका ये क्लास देख के मुझे दिल करता है कि मैं फिर स्टूडेंट बन जाऊं, आपके लेक्चर सुनूं, क्योंकि हम इतने खुश नसीब नहीं थे कि आप जैसे उस्ताद मिले हमें।
सर
आपके तो उस्ताद बहुत अच्छे।
सर आपके जो उस्ताद है ना, मैं तो ये समझती हूँ कि आप जो हमारे उस्ताद हैं, यू आर रीजन फॉर बीइंग हियर, और जो कुछ है वो आपकी वजह से है, आपकी सिखाई हुई चीजें हैं। आई एम नथिंग, इट्स ऑल बिकॉज़ ऑफ यू।